Our next speaker is from the EMA. Carolyn Orish-Beneshu is a pharmacist and a biologist. After a hospital career, she entered the French Medicines Evaluation Agency in 1996, where she took charge of the clinical assessment of marketing authorization dossiers. She started taking charge of rare disease dossiers in 2003 when she was rapporteur to assess the marketing authorization dossiers via the centralized procedures at EMA of a number of mucopolysaccharidoses and lysosomal diseases. She was a member of the Efficacy Working Party from 2005 to 2010 when this working group disappeared, and was the rapporteur for the guideline of development of drugs for cystic fibrosis. Since 2010, she is the head of the scientific advice in the French Medicines Evaluation Agency, ANSM, and is a member of the Scientific Working Party in EMA, particularly devoted to the coordination of advice in the field of rare diseases.
So, yes, good morning, everybody. You'll see my presentation is just to give some thoughts where the European Medicines Agency is now with the evaluation of rare disease, and we have absolutely no definite positions. We are evolving every day, specifically in the field, each time we meet companies for scientific advices. What I can suggest briefly presenting, so as you understood, I'm responsible for scientific advice in the French Medicine Agency, and because you know that the European Medicines Agency has several groups and marketing authorization commission composed of representatives from all the member states, and I'm in the Scientific Advice Working Party, which is in charge of answering companies' questions, specific questions on the development. What I can say to introduce in the field of rare disease is that we know all, what's for sure is that we have specificities in rare disease, but in the end what we want is, as far as possible, the same quality in the evaluation the patients deserve, receiving a drug, having been assessed according to the same level of quality, and the same level of benefit-risk assessment. But of course, there are specificities, which means that the paradigm of two well-controlled randomized clinical trials with parallel group and placebo to have a true effect size and the true knowledge of safety, and perhaps a comparator to contextualize and no loss of chance. This is not always applicable and rarely applicable to rare disease. So what we have learned is to adapt, due to the fact that in view of the small population and competing fields, we have small sample size, and so we need to adapt the means to achieve this high-level quality. So usually, as my FDA colleagues said, one pivotal trial to us might be enough, but it should be accompanied by a lot of non-clinical proof of concept, and most importantly, it doesn't end at the time of granting a marketing authorization. It should continue with collecting long-term efficacy and safety data, often real-world, and often in the frame of registries, and we often request registries. That said, that was to introduce the fact that the presentation will focus on examples of specificities as regard endpoints in rare disease and and I try to find examples in mucopolysaccharidosis, and also examples of some specific design that we have either accepted or recommended because the paradigm of group parallel RCT was not possible. So, so I started with pharmacodynamic endpoint because it is always the one that are the most evident to measure, what can be easily and rapidly measured. and in the MPS also. We have had a lot of proposals for urinary GAGs or CSF GAGs or leukocyte glucosaminoglycans. But, and it's true, but we consider, and I think that FDA colleagues said almost the same, that it is not enough to demonstrate an efficacy in a confirmatory or pivotal trial. What we need, because in the end, marketing authorization relies on the consideration that the benefits outweighs the risk, we need to have, to define a clear, true benefit for an individual, for a patient. And the benefit for the patient means a clinically meaningful primary endpoint. So pharmacodynamic endpoints are never accepted as a sole primary endpoint. We need, but these pharmacodynamic endpoints are still very important, because when collecting clinical endpoints, in the frame of so restricted sample size, where studies are often not powered to be clinically, statistically significant on clinical endpoints, the effect on pharmacodynamic parameters will ascertain that the clinical effect observed is actually due to the treatment effect and not to disease fluctuation or something like that. It can be sometimes accepted as a so-called primary just for statistical significance purposes. But what will be important will be to assess all the clinical endpoints. We accept pharmacodynamic endpoint for phase 2 studies, dose finding studies, but not for... So, as I said, what we need is clinically relevant endpoint, because they measure the true benefit. And we not only, within this clinically relevant endpoint, you have endpoints that are more or less also pharmacodynamic, measuring just what is the defect, the clinical defect, measuring the symptom, such as muscle trends in SMA or cognitive endpoints. But what we need to have an idea of the benefit is to have endpoints really to show a benefit. You have to show an endpoint with consequence on the everyday life of the patient, which might be activities of daily living or behavioral endpoint, apart from cognitive endpoints about social interaction, language, effect on sleep. These are really immediate benefit for the patient. Saying that you have gained some 1 or 2 or 3 points on the cognitive scale is good, but showing that actually it translates into the fact that the child has better sleeping, that is key to say that it deserves being granted a marketing authorization. Then what should be a good criteria? It has been also covered by FDA already. The candidate should be sensitive to change. And for that, it's very important when you choose a scale. When you have a 4-point scale, of course, you will not be able to measure slight changes and to assess whether they translate into an actual clinical benefit. So when you have scales with a lot of items, often they are more adapted to detect smaller changes. They should allow to define a clinically meaningful, important difference to say, well, we know that when you achieve this difference, this is of clinical relevance. They should be validated according to the full range of severities and ages of the disease. Often we have small population. We cannot, we are not expecting having one population in the very young and one in adult. Often it's all mixed, and we need that it be validated across the full range. It should be objective, which means that we always, and this is our position as regard PRO currently, I mean, we are very reluctant to grant a marketing authorization on a primary clinical endpoint or on a clinical endpoint that is only a patient-reported outcome or a physician global impression of change, because it might be subjective. It might be, and we always prefer that we have objective ones, but you will see that finally it doesn't matter a lot because we don't often in very rare disease and MPS, we don't have one primary endpoint. We consider the totality of evidence. And it should have low intra-individual variability. When you have a high intra-individual variability, we often request that the measurement for a given time point is repeated several times, 2 or 3 times with a given interval. And it should have, as soon as possible, low inter-rater variability, which can be, again, in turn, partly compensated by training the raters. And often we request that the company use several independent raters that are scoring based on video taping, video recordings, and we assess the concordance level between raters. And as I said, statistical significance on the pharmacodynamic endpoint is not sufficient, and we know that probably the study won't be powered enough to reach a statistical significance on the clinical endpoints. That's why, as we say, the EMA position is to assess the total body of evidence. And as I said, notion of primary or secondary endpoint lose some significance here. What we want is to see a consistent, favorable trend in key clinically relevant endpoints associated with the statistically significance effect on pharmacodynamic parameter and proof of concept at the non-clinical level. We really assess this total body. However, when you have a lot of clinical endpoints, it's good to try to hierarchize them in terms of this clinical relevance, what we are looking for most. And this was stated I mean, it's been a long time since we are thinking this way, and we have a guideline in EMA, which is the guideline in small populations that was drafted in 2005, and it states that collectively, if data look compelling and enable estimation of a treatment effect and of a confidence interval, this is more informative than a p-value in the context of very rare disease. And it was translated in the first, I found the first scientific advice in MPS 2, in which in 2002, as early as 2002, we said that they don't have to propose a primary pharmacodynamic primary endpoint to have statistical significance, or you don't have to choose the clinical endpoint because it is the more likely to reach to give rise to statistical significance. You should choose a clinical endpoint because it is the one that is reflecting best the benefit for the patient. And that's why, for example, in MPS 3A, not on having a primary endpoint on stabilization of DQ is the perfect demonstration of the effect of the drug, but we want also assessment on sleep disturbances and behaviors. I don't have time any longer. I'm in.
Give me 5 minutes.
So.
5 minutes.
So very briefly, I try to make some consideration of also on what could be alternative to this parallel group RCT classical design. And so the first thing is the comparator. Normally we want a comparator, and it's always preferable to have a comparator. But we know that it is not always possible to have no active comparator exist most often in this disease, and a placebo is often not ethical because the absence of treatment would lead to irreversible damage, or we have such a restricted sample size that dividing this sample size into active and placebo would lead to too few data in each group, especially when you have a high heterogeneity of the factors for disease progression. So in that sense, we have, I have reviewed what we have already either accepted or recommended, mainly for mucopolysaccharidosis in the frame of scientific advices in EMA. Most often, this is the most currently, I think it is the alternative that has been most used is external controls as an alternative to internal control, which means historical controls. I have listed the conditions, and when it is particularly adapted, as I said, it's particularly adapted when the natural history shows that there are milestones that are never achieved. For example, they are never alive after a given age. And for MPS IIIA, we know that the DQ, which is the developmental age divided by the calendar age, is always going to steadily, linearly decrease for a given patient from the beginning. So if it's stabilized, if the patient is alive after a certain given age, we know that it is efficient, and an uncontrolled one single arm study could be acceptable. We have also other alternatives that has been accepted. For example, for MPS IIIA, also we have accepted in scientific advice, because we have so many prognosis factors for progression that it is impossible to ensure that even if we have enough patients, that the controls, be it in placebo arm or as historical control, they cannot be matched exactly to the patient. You cannot ensure that the only difference between the placebo arm or the historical controls and the treatment arm is the nature of the treatment. Because you should, for example, for MPS IIIA, you should match age at appearance of first symptoms, age at diagnosis, which is sometimes different, and a baseline developmental age, and it's quite impossible. So in that sense, the patient might be its own control. You just have to have a previous baseline observation period, so our sufficient direction, the sufficient duration to ascertain what is the individual pattern, and then you assess the change in individual pattern, provided, which is the case in MPS IIIA, that you can predict what will happen for a patient in the future if you do not give any treatment, which is the case for MPS IIIA with a linearity of decrease of DQ, for example. Then we have very briefly, but I can, a randomized withdrawal and rechallenge design, which might be really interesting. You can treat a patient on an open label, and then you observe until you observe an effect. And then you have a small, it's when it's impossible to randomize, it's impossible to have historical control and things like that. Even sometimes we request natural history studies being conducted, but sometimes there are so restricted sample size. And so in the second period, you randomize between active and treatment. And the null hypothesis, you test the null hypothesis that the observed effect in the first period was not due to treatment, but due e.g. Disease fluctuation. And then you can, and you randomize only responders, which means that you are not exposing non-responders unduly to the drug. And you minimize placebo period because generally loss of response is more rapid. And then you re-challenge by retreating patients. And when you have observed an effect, then observe loss of the effect upon cessation of treatment. Then observed again this effect reappearing upon reintroducing treatment. You have a level of proof that might be much more robust when other things are not possible. And the very last one, and this, for example, was accepted for a rare disease recently, pyruvate kinase deficiency. We accept this randomized withdrawal and rechallenge design, for example. It was very extra rare disease with less than 200 patients worldwide. And the last thing is when you cannot at all compare even with external controls for a lot of reasons, mainly because it's extremely rare, so rare that you don't even cannot conduct a natural history study. You can introduce some randomization by randomizing the time to starting treatment. It's what we call immediate and delayed start. It's inspired of the N of 1 design. When you have multiple intra-patient comparisons, because you have multiple crossovers between active and placebo, and we have recommended it, for example, in scientific advice for MPS CVAN when we have only 8 to 12 patients, and we have a blinded shift to active at various time points. I think that just in conclusion, I said that the choice of the design is conditioned by the need for control data and the availability of how we can fire control, but that it is always a case-by-case basis, and we always encourage companies to come for scientific advices which are free of fees for small and medium companies, and when you had an orphan drug designation in the EMA. Sorry for being late.